Stand up. Go on, I'll wait. Get up from wherever you are. If you're driving or you're holding a hot cup of coffee, that's all right. Wait until you put it down. Find yourself a wall within reach, but don't touch it. Lift 1 foot off the floor. Bend that knee a little. And count, in your head, all the way to 10. Now, while you're doing this, I want you to notice something. Not to notice what I'm saying. Notice what's happening to you. Feel the little twitches in your ankle. Feel the muscle under your knee, pulsing. Your hip is doing something funny, working like a lever, but a lever you can't see. And somewhere behind your eyes, down at the base of your skull, something is calculating, very fast. Something like 1,000 corrections a second going out to your muscles before you have any idea corrections are needed. You're not lifting anything. You're not pushing anything. You're just standing still. And yet your body has done more computation in the last 5 seconds than you'll do in your head for the rest of the day. Well, why is your doctor not testing this? Let me tell you what I found out. Because I wasn't looking for it. I was reading about something else entirely, and I came across this business, and I thought, this is just wonderful. This is physics. This is the kind of thing you don't expect it. You don't think, when you stand up on one leg, that what you're really doing is the most difficult problem in control engineering that the human body ever attempts. But it is. Now. Before we can talk about what goes wrong, I want to tell you what's actually in there. Because most people go through their whole lives and they don't know what's inside their own bodies. Not at the level that matters. So let me give you a little tour. You have 3 separate balance systems, all 3 of them running, all 3 of them, all the time. They don't take turns. They don't vote. They all feed into one place. And that one place is a structure at the base of your brain, tucked in behind the brainstem, about the size of a plum. That is called the cerebellum. We'll come back to it. First, the floor, under your foot, under the sole of your standing foot, and up through the muscles of your foot, along the arch, in the ankle, in the calf, in the thigh, all the way up into the small of your back. You have thousands of little sensory endings. They're called muscle spindles and Golgi tendon organs. Those are biology names. What they do is physics. They count. They count how long a muscle is. They count how much tension a tendon is under. They count the microscopic stretching of one piece of connective tissue against another when your weight shifts even 0.5 millimeter. And they send the information up your leg along nerve fibers called Group 1A afferents. Now these fibers, these are the fastest wires in your body. Conduction velocities of up to 100 meters per second. Faster than the neurons that carry pain. Faster than the ones that carry temperature. The fastest wire you own, dedicated to one question. Where is the ground? Now here is a thing I did not know. There's also your skin. The sole of your foot has 4 different kinds of mechanoreceptors, 4 kinds of pressure-sensing endings, each one tuned to a different kind of touch. One for steady pressure, one for light shift, one for skin stretch, one for vibration. And every little patch of your sole has hundreds of them. When you stand barefoot on a wooden floor, the grain of the wood is being measured. The temperature difference between your heel and the ball of your foot is being registered. A Swedish physiologist by the name of Åke Valbo spent 40 years recording from single nerves in human volunteers, and he mapped this whole business. The foot, it turns out, is a precision instrument. Your feet are not cushions for standing on. They are measuring devices. Above that, behind your ear, buried in a piece of bone that is harder than any other bone in your body, they call it the petrous part of the temporal bone, sits a little factory of fluid and membrane called the vestibular labyrinth. 3 loops arranged at right angles, 2 pouches at the base of them lined with hair cells. And sitting on top of the hair cells is a gelatinous blanket with tiny crystals in it. The crystals are about 5 to 7 micrometers across. They have a specific gravity of about 2.7, which is roughly the density of limestone. So what you have inside your head, behind each ear, is pebbles of limestone suspended in jelly. And you have been using these pebbles to tell you which way is down since before you could walk. Now the 3 loops, those are the semicircular canals. When you turn your head, the fluid inside each loop lags behind for a fraction of a second. And the lag bends the hair cells on the wall of the loop, and the bending triggers a signal. I want you to appreciate what this is. You have a gyroscope in your ear. This is not a metaphor. The mechanical principle is exactly the same one we use in aircraft instruments, except our instrument runs on salt water and proteins, and it has been working for about 500 million years without being serviced. The 2 pouches, they call them the utricle and the saccule, those do linear acceleration. When your head tilts forward, the limestone pebbles slide on top of the hair cells, and they drag the hair bundles along with them, and the hair cells fire. One pouch handles sideways motion. The other handles up and down motion. Together they tell you when you are falling, well before you have noticed you are falling. And above that, still higher, at the back of your skull, below the big bulk of your cerebrum, sits that cerebellum, Latin for little brain. And here is a thing that surprised me when I first read it. Your cerebellum contains more neurons than the rest of your brain put together. Something like 70% of all the nerve cells in your head live in this one little organ, the size of a peach. And you know what it does? It predicts. That is all it does. It takes the orders the motor cortex sends out to your muscles, every little adjustment, every flex, every small correction. And it makes a prediction about what the sensory data will look like when the order is carried out. Then it compares. It compares the prediction to what really happens, and the difference is what it uses to correct. All of this below your level of awareness. By the time you have noticed you are swaying, the cerebellum has already sent the correction. Okay. That is the anatomy. Now let us look at what actually happens the moment you lift that foot. The instant the lifted foot leaves the ground, all the receptors in that foot's sole go quiet. No pressure. No contact, nothing to report. But the receptors in the sole of the planted foot, which had been sharing the load with the other side, suddenly have to carry the whole weight of you. A person of 160 pounds is now standing on a patch of skin about the size of a paperback book. And here is something nice. Most of the muscle spindles in your foot were silent a second ago. There is research published in Experimental Physiology that shows roughly 70% of the spindle afferents in your foot muscles are not firing when that foot is not bearing load. They are waiting. The moment you shift your weight onto that foot, they wake up. They start firing what is called tonically, that means continuously, and the rate they fire at encodes the trajectory of your center of pressure. That is the single point. On your sole, where the entire weight of your body passes through. And that point moves, a few millimeters at a time, while you are trying to stand still. Your foot is tracking that moving point the way a radio dish tracks a satellite, to keep a column of bones of this weight from tipping over. Now the information goes up your leg on those Group 1A afferents, reaches your spinal cord in less than 10 milliseconds. And here is the thing that is wonderful to a physicist. It does not wait to ask the brain what to do. The spinal cord has a direct one-synapse connection between the spindle signal and the motor neurons that control the same muscle. It is called the stretch reflex. If your calf is suddenly being stretched because you have started to fall backward, the spindle fires, the motor neuron fires, the calf contracts. No thinking, no awareness. Your calf has caught you before the fall has reached the threshold of your conscious experience. A fellow by the name of Robert Paterka at the Oregon Health and Science University published a paper in 2002 in the Journal of Neurophysiology. And what he did was figure out quantitatively how much each sensory system contributes to your postural control when you are standing quietly on a firm surface with your eyes open. 70% comes from proprioception, the muscle spindles and tendon organs and skin receptors in your foot and leg. 20% from the vestibular system, the ears. only 10% from vision. You read that right. When you are standing still on solid ground, your eyes are the least important balance organ you have. Now close your eyes. Try standing on one leg with your eyes closed. That 10% is gone. The other 90% has to cover for it. Most people over 70 cannot do it for more than a few seconds, and the reason is not their vision. The reason is that the proprioceptive floor has developed holes. As you get older, the muscle spindles get worse. The myelin insulation around the afferent nerves degrades, and the signals slow down. Conduction velocities drop. The density of sensory endings in the sole of your foot decreases. A signal that used to reach the spinal cord in 10 milliseconds now takes 15. That extra 5 milliseconds is enough. A small sway becomes a large one. A large sway becomes a fall. This whole business is happening while you count to 3. But the floor scan is only one branch of what is happening. The data leaving your leg is going 2 places at once. One branch stays down in the spinal cord and runs the reflex loops that adjust your calf and your thigh. The other branch climbs up a pathway called the spinocerebellar tract and heads up toward the cerebellum. But before any of that matters, a muscle that nobody ever talks about has to do its job. Put your hand on the side of your hip, right under the bony ridge at the top of your pelvis, on the upper side of your buttock. Under your palm is a fan of muscle that runs from the top of your pelvic bone down to the knob at the top of your thigh bone. That is the gluteus medius. Behind it there is a smaller one with the same orientation, the gluteus minimus. Both of them are your hip abductors. They both take orders from one nerve called the superior gluteal nerve. When you are standing on 2 legs, these muscles do not do much. They are just along for the ride. But the moment you lift a foot, they become the most important muscle group in your body. Let me show you the mechanics of this, because this is physics. When you lift your left foot, your right hip becomes a fulcrum. The weight of your torso, plus the weight of your lifted leg, hangs off one side of that fulcrum. And the only thing keeping the pelvis level is the gluteus medius on the right side, pulling down on the right side of the pelvis to counteract that load. If the muscle did not pull, or if it could not pull hard enough, the pelvis would tip. The left side of your pelvis would sag by 5-10 degrees. Your whole torso would start to twist to the left. You would collapse. The lever ratio here is terrible. The distance from the gluteus medius to the hip joint is short. The distance from the hip joint out to the middle of your body is long. So the muscle has to generate something like 2.5 times your body weight in contractile force on one side to keep your pelvis level on the other side. That is the physics. It is a class 3 lever, and it is working against you. When the gluteus medius gets weak, the pelvis drops. A German surgeon named Friedrich Trendelenburg noticed this back in 1895, and he put his name on it. A positive Trendelenburg sign, that is the name of the observation, is when you stand somebody on one leg and the opposite side of their pelvis sags. It is the single most common physical finding in an elderly patient who has just failed the 10-second test. The muscle is not injured. The nerve is not cut. The person has simply stopped asking the muscle to do its job decades ago, and the motor cortex, being lazy, has let the circuit fade out. Your gluteus medius is a use it or lose it proposition. It is not like your heart, which beats whether you want it to or not. It is more like a language you learned in school. You stop speaking it at 25. By the time you are 65, you cannot order a coffee in it. And while all of this is going on at your hip, something has already been happening inside your head that you do not notice at all. Your head is tilting. You cannot feel it, but it is. Every microsecond your center of mass moves, your skull is making little angular and linear adjustments to keep your eyes aimed where they need to be aimed. And inside your inner ear, the fluid in those 3 little semicircular canals is sloshing around. The limestone pebbles in your utricle and your saccule are sliding, a fraction of a micrometer at a time, in the direction of the shift. Now here is the transduction. This is the physics of how a mechanical tilt turns into an electrical signal. Each hair cell in your vestibular system has between 40 and 70 tiny hair-like projections called stereocilia, bundled together, embedded in the gelatinous membrane above. When the membrane slides, the stereocilia bend. When they bend toward the tallest one, which is called the kinocilium, a mechanically gated ion channel pops open in the tip of the hair. Potassium floods in. The hair cell depolarizes. It releases glutamate, which is just a neurotransmitter, a chemical messenger, onto the vestibular nerve fiber sitting at its base. The nerve fiber fires. The signal enters the vestibulocochlear nerve, that is cranial nerve 8, and reaches the vestibular nuclei in your brainstem in less than 4 milliseconds. And now the vestibular nuclei send 3 signals at once. One goes to the muscles of your eyes to keep your eyes stable as your head moves. That is called the vestibulo-ocular reflex. It is how you can look at a fixed point on the wall and still read the text printed there even while your head is wobbling around. You have probably never noticed this reflex working because it never fails at a scale you can detect. But if it were turned off, if I could put headphones on you that scrambled the vestibular signal for 1 second, the whole world would blur. That's simple. The second signal goes down the vestibulospinal tract to the muscles of your neck and your trunk and your legs. It tunes muscle tone. It gets the muscles ready for the correction your cerebellum is about to command. The third signal goes up to the cerebellum itself, joining the stream of data already flowing in from your leg. A researcher named Yuri Agrawal at Johns Hopkins University looked at the National Health and Nutrition Examination Survey, that is a big study run by the government in the United States, and she found in 2009 that 69% of Americans between 70 and 79 have measurable vestibular dysfunction, not severe, not dizziness in the clinical sense, just quiet erosion. The hair cells die off. The otoconia, those limestone pebbles, develop pits and fragments. The vestibular ganglion, called Scarpa's ganglion, loses neurons. A person who could compensate for a small sway at age 50 can no longer compensate for the same sway at age 75. Imagine a woman over 65 with declining vestibular function. She does not know it is declining. What she knows is that the stairs feel different. That turning her head quickly makes her briefly unsure of herself. That she has started avoiding the top step of the bus, holding the railing a second longer than she used to. The nerve endings are reporting less. The pebbles have shifted. The hair cells fire with a little more noise than they used to. Or her husband, 72 years old, still walks 5 kilometers every morning on the flat path by the canal. His heart is excellent. His blood tests are clean. He is the patient who looks well at every annual physical. When his doctor says the results are fine, he believes it, because on every measurable cardiovascular metric they are. Nobody has ever asked him to stand on one leg. In one of these studies, of 24 participants aged 85, only 2 could complete the 10-second test. Of the ones 76 to 80, 70% could not. At about age 70, half the people in the study had already lost the ability. This is not a gradual slope down from your 50s. This is a cliff that opens under your 6th decade and steepens from there. If you do nothing, by the time you are old enough to worry about falls, the system that would prevent them has already largely gone offline. 3 streams, foot, hip, ear, are all converging on one structure. And the structure has been predicting what they were going to say for half a second before they said it. Put your hand on the back of your skull, just where it meets your neck. Your palm is now over your cerebellum. Inside there, a prediction engine has been running. Every command your motor cortex sent down to your leg was copied, a neural carbon copy, and sent laterally into the cerebellum. The cerebellum used those copies to predict what the sensory signals should look like when the command was carried out. Then it compared the actual signals to the prediction. The difference, the mismatch between prediction and reality, is what they call a prediction error. And the cerebellum has one job, which is to minimize that error in real time, not after the fact, not by reviewing the last 5 seconds, but moment by moment, continuously adjusting the motor commands so that the next prediction is a little better than the last. This is why a dancer looks effortless. Her cerebellum has narrowed the prediction error down to something very close to zero. Her body is not correcting for errors anymore, it is anticipating them. The workhorse cell of the cerebellum is called a Purkinje cell, named for a Czech anatomist Jan Evangelista Purkinje, who described it in 1837. Each Purkinje cell has a dendritic tree so elaborate that it looks like a fan coral, a flat spray of branches, and it receives input from as many as 200,000 other neurons. Each of those inputs is a little vote. Yes, the command was right. No, it was off by this much. The Purkinje cell counts all 200,000 votes and fires a single output signal down to the deep cerebellar nuclei, which in turn adjust your brainstem, which in turn adjusts your muscles. This is the narrowest bottleneck in your motor system. It runs at extraordinary speed. And when it fails, you fall. When you stand on one leg, your cerebellum is running this loop about 100 times a second. Now here is something nice. In healthy young adults, when they stand quietly on a firm surface, the cortex is barely active. EEG recordings show almost nothing from the cortex at all. The thinking part of your brain is not involved. The job is being handled entirely by your spinal cord, your brainstem, and this little peach-sized cerebellum. A research team at the Catholic University of Louvain, publishing in Scientific Reports in 2024, found that the sensorimotor cortex only starts tracking postural sway when the task gets hard, standing on foam with the eyes closed, and the tracking happens in a specific frequency band between 1 and 6 Hz. Below that threshold, your cortex is free to think about dinner. Above that threshold, your cortex is forced into the balance task, and the cortex is much slower than the cerebellum. That is why older adults, when their balance starts failing and the cortex has to take over, cannot carry on a conversation and walk at the same time. The dual task penalty, as they call it, is literally the cortex being asked to do 2 things that share the same bandwidth. Now, patients with cerebellar disease show all of this very clearly. Hans Christian Diener, a neurologist at the University of Freiburg, back in the 1980s, did quantitative posturography on 41 patients with different cerebellar lesions. His findings are still cited today. People with anterior cerebellar lobe atrophy show a characteristic tremor at 3 Hz, 3 sways per second, unmistakable on a force plate. Patients with vestibulocerebellar lesions show a different signature. A single structure the size of a peach contains subregions, each of them dedicated to a different axis of postural correction. Your cerebellum is tired. In the 10 seconds of this little test, it has done more computation than your cortex will do in an hour. All of this, the floor scan, the hip contract, the vestibular correction, the cerebellar prediction, has been running continuously from the moment your foot came off the ground, not sequentially, all at once. Which brings us to what the Brazilian cardiologist discovered. Now, I want to pause here, because I am a physicist, not a biologist, and when I talk to you about biology, I have to be honest about what I am confident in and what I am not. The anatomy is not in dispute. The muscle spindle, the Golgi tendon organ, the otolith, the cerebellar vermis, these structures have been dissected, stained, photographed in thousands of specimens over 150 years. The wiring diagram is settled. The sensory percentages, 70 proprioception, 20 vestibular, 10 vision, those rest on Pederka's paper. They have been replicated across multiple labs. That is mature science. The age-related decline of the vestibular system is also well documented. 69% of people between 70 and 79 show measurable dysfunction. Hair cells are lost. Otoconia fragment. The decline begins in your 6th decade and accelerates thereafter. Also mature. Also replicated. The Trendelenburg sign is more than a century old. Whether the gluteus medius weakness is the primary cause of falls or whether it is a symptom of broader deconditioning is still being worked out. But the biomechanics of that lever are not in doubt. The cerebellar prediction model, the forward models, the prediction errors, the cortical frequency bands, this is newer. The broad outline is accepted by nearly everyone studying motor control. The fine details are still being worked out. Good science takes time. And then there is the mortality finding. Claudio Gil Araujo at the Clinimex Exercise Medicine Clinic in Rio de Janeiro published in the British Journal of Sports Medicine in June of 2022. He followed 1,702 adults between 51 and 75 for a median of 7 years. And he found that people who could not stand on one leg for 10 seconds had an 84% higher risk of dying from any cause, after controlling for age, for sex, for body mass index, and for other illnesses like heart disease and diabetes. Now, this is an observational study. It cannot prove that the inability to stand on one leg causes earlier death. The direction of causation is still open. It could well be that the balance failure reflects a frailty in several underlying systems, cardiovascular, muscular, neurological, all at once. Naveed Sattar at the University of Glasgow, commenting on the findings, called the one-legged stand a global test of future mortality risk. Not a direct cause, a summary statistic. But even a summary statistic has enormous predictive value. For people between 51 and 75, the 10-second test was a stronger predictor of dying than a prior diagnosis of coronary artery disease, stronger than a diagnosis of high blood pressure, stronger than elevated cholesterol. Araujo, who had been working with cardiac patients for 4 decades, said he was impressed by what he had found. Whatever the underlying mechanism, the signal is clear. A body that can no longer coordinate a 10-second one-legged stance is a body that is failing in multiple systems at once. That is what your doctor has been missing. Let me tell you what happens when somebody fails the test. About 300,000 Americans 65 and older break a hip every year. The fracture is almost always the consequence of a fall. The fall is almost always the consequence of a balance failure of one or more of the mechanisms we have just walked through. Within 12 months of that fracture, between 20 and 30% of those patients will be dead. Of those who survive, only about half will walk unaided ever again. Many will never leave an institutional setting. Worldwide, the World Health Organization estimates that falls kill about 680,000 people every year. It is the second leading cause of unintentional injury death on the planet, behind only road traffic. More than 37 million falls a year require medical attention. Among older adults in the developed world, one single fall can start an institutional trajectory that many never reverse. The fracture is the first domino. Everything downstream goes. The cost per hip fracture patient averages about $50,000 in the first year. That is from Medicare data analyzed in 2014. The total bill to the United States health system is about $6 billion a year. Globally, there are about 1.7 million hip fractures a year in people over 50. By 2050, the number is projected to reach 6 million. Now, consider the interventions. To prevent the osteoporosis that makes the fracture possible, people get prescribed bisphosphonates, drugs like alendronate and risedronate, a few hundred to a few $1,000s a year, depending on the formulation and the country. The way they work is nice. They bind to the hydroxyapatite crystals in your bone matrix. And when the osteoclasts, those are the cells that dissolve bone, come along and try to take up a crystal with a bisphosphonate stuck to it, the bisphosphonate interferes with the enzymes the osteoclast uses to do its dissolving. So the bone does not get resorbed as fast. The drug reduces hip fracture risk in patients with osteoporosis by something like 40%. Real medicine. And to treat the balance dysfunction that leads to the fall, people get vestibular rehabilitation therapy, a course of 6 to 8 weeks, several hundred to a few $1,000s, and you get about 70% improvement in balance scores. A doctor by the name of J.D. Macias and colleagues published an early demonstration of this in otolaryngology head and neck surgery back in 2005, and lots of trials since have confirmed it. These interventions are useful. Some of them are necessary. If your bones are already fragile, you need the drug. If you are already unsteady and afraid of the next fall, you need the therapist. I am not telling you to throw these out. But here is the curious thing. When you stand on one leg and force your cerebellum to run that prediction error loop at full bandwidth, you are exercising the exact same circuit that vestibular rehabilitation therapy is training under clinical supervision. The gaze stabilization exercises, the single limb stance drills, the foam surface tasks, they are all engineered to generate prediction errors in your cerebellum and drive it to adapt. And the cerebellum adapts through the same synaptic mechanism that makes any motor skill improve with practice. Long-term depression at the parallel fiber to Purkinje cell synapse, the same molecular machinery, the same second messengers, the same calcium-dependent cascades. When you stand on one leg every morning while you brush your teeth, you are running a home version of the clinical protocol. The dose is lower. There is no therapist. A person with an existing balance disorder cannot substitute a toothbrush for proper care. But a healthy 55-year-old who does this for a minute every morning is, at the cellular level, doing the same kind of thing a formal program does. Slowly. Over years. The underlying story is neuroplasticity. When you push the balance stack into difficulty, the sway, the wobble, the near fall, you generate a prediction error big enough for the cerebellum to notice. The cerebellum does not change its forward model for free. It needs error. The error drives the long-term depression at Purkinje synapses. The motor cortex, meanwhile, expands the patch of cortical territory dedicated to that foot. This is called cortical remapping. It happens in healthy adults. It happens in older adults. It even happens in stroke patients who recover balance through targeted training. Your brain has been doing this since you were born. You just stopped asking it to. I am not criticizing bisphosphonates. They work through a pharmacology your body cannot reproduce. If your bones are brittle, take the drug. What the daily practice does is upstream of the drug. It reduces the chance that you will ever need to find out how well that drug works in your particular hip. The difficulty is not a sign that the exercise is wrong. The difficulty is the exercise working at the intensity it needs to work at in order to change anything. If standing on one leg feels hard, that is the cerebellar prediction error loop firing the way it is designed to fire. The fatigue in your hip abductor is the gluteus medius reawakening a motor unit it has not spoken to in 5 years. The little sway that makes you reach for the wall is the vestibular system recalibrating a gain it lost 2 decades ago. None of this is free. It costs attention. It costs 2 minutes a day. It costs the discomfort of noticing that something you used to do without thinking now takes some work. What it does not cost is $50,000 and 6 months in a nursing facility and the possibility that the hip on the other side of the fall never quite works the same again. Isn't that funny? Older physiotherapists used to tell their patients something, not the young ones, the ones who were trained in the 1960s and 70s, who had watched 4 generations of elderly patients come through their clinics. They would send a patient home with some exercises, and they would tack on a piece of advice so simple the patient usually forgot it by the time she got to the car. Practice standing on one leg while you brush your teeth. That was it. No prescription, no device. Just a daily 30-second reminder, built into a habit you were already going to do, that forced the whole balance machinery to stay online. The proprioceptive floor scan, the hip abductor contract, the vestibular correction, the cerebellar prediction loop, all of it, while your hand moved a brush across your teeth. They knew what the British Journal of Sports Medicine would publish in 2022. They had seen it in their own patients. The ones who could still do it at 80 were the ones who had been doing it since they were 65. The ones who could not do it at 80 were usually the ones the clinic stopped seeing soon after. because they had stopped coming in on their own 2 feet. Now. Put the phone down. Stand up. Lift 1 foot. Count to 10. The mechanism is yours. It has always been yours. Use it. Tell me, how many seconds did you get on your first try? I would like to know.